So we had some discussion this week about ketones in the chat channel, and there was some variation in practice between the consultants, for example, and I just wanted to clarify a couple of thoughts on ketones because it's a very frequent issue that comes up in emergency, and yes, there's some controversies, but there are also some basic misunderstandings at play. So I've got a couple of points. The main 3 points I want to get across are: one, ketones are not a measure of hydration. They're a measure of starvation, or in other words, substrate depletion. Secondly, ketones cause nausea, vomiting, and sometimes abdominal pain. And thirdly, the treatment for raised ketones is not fluid, it's glucose or carbs. So point one, ketones are a measure of starvation. Most of the kids that we see with high ketones in our department have gastro, or they've had poor oral intake from another cause. So people start to associate dehydration with ketosis, but hydration is a measure of your body's fluid intake, whereas ketones rise in response to low nutritional intake, particularly when you're not having enough sugar. So because we often measure ketones and sugar in sick kids with vomiting and diarrhea, ketones are often high, people start associating that with being a sign of dehydration, and it's not. So if we want to assess dehydration, then we mostly need our clinical skills, clinical examination, and the history of the urine output, and maybe electrolyte balance if it's a severely dehydrated child. But ketones will not give you a marker of how dehydrated that patient is. It will, however, give you some evidence that the child hasn't been having much sugar or carbs. So particularly a kid who has like a ketone of 5 or 7, that to me is starting to say this is a very substrate deplete child. So point 2, ketones can cause nausea, vomiting, and sometimes abdominal pain. So this means that a child who is substrate deplete might actually be over their viral illness sometimes, but start vomiting again purely from their ketosis, which becomes a self-perpetuating cycle of starvation leading to further vomiting, and they can't get themselves out of it, so they can get really sick and really miserable. Occasionally, really ketotic kids can come in and actually have quite sore bellies, and I've seen a couple that have been started down an appendicitis workup pathway, but they've just been really running low on sugar. So if you're hearing a story of a kid who's had vomiting, and then they've had diarrhea, and then the diarrhea is settling, and then the vomiting has returned, then that kid's probably ketotic rather than just having a prolonged viral gastro, and they can't get themselves out of it. So we have to help them break that cycle. Other kids who get ketotic are also those who will refuse to drink anything but water when they're sick. So they might have had plenty of total body water, but they've become ketotic because they're running low on sugar. So their volume replete, but their substrate deplete. So point 3, treating ketosis needs substrate, not fluid. And this is where things get pretty complicated because we've got a lot of options. So we can treat the ketosis, not the hydration, in a number of different ways. And you've got to match up their hydration needs and their substrate needs and find a good medium for your particular patient. So for kids who can tolerate oral intake after ondansetron, they basically just need a shit ton of sugar and carbs to clear their ketosis. So if they're dehydrated as well, then things like apple juice might be a good choice because it's very high in sugar. Now, hydrolyte is a bit more isotonic. So if they're severely ketotic, it's sometimes not enough to switch off their ketone production, even if you're treating their dehydration. For dehydrated kids who aren't tolerating orals, we've got 2 options, right? We've got NG feeds or IV fluids. And if we're going for NG feeds, then you can consider hydrolyte rehydration in kids with a very mild ketosis, and that might be enough if you've given them enough volume, because there is sugar in it. But for the more severely ketotic kids, like the kids with 5 to 7, I think it's worth considering whether they're going to need more substrate to switch off their ketones. So you could consider giving them formula as a better option, since it gives them some complex carbs and will give them nutrition as well as rehydration. For children with ketotic hypoglycemia, which is kind of another talk all in itself, they are going to need either formula or polyjewel, which is a higher concentration of glucose in it than hydrolyte, and we have a recipe for it on the pediatrics ward and in the ketotic hypoglycemia guideline. So for kids who are needing IV rehydration, so whether they are just continuing to intractably vomit or they just look really sick and shocked, we need to consider what are their fluid needs and what are their substrate needs. So in a child who is not shocked, who has ketotic hypoglycemia, then normal saline and 5% dextrose is not enough to switch off their ketone production. So it kind of keeps them sitting in that cycle. So we actually need to give them normal saline plus 10% dextrose. And the recipe is in the hypoglycemia guideline, but it's all you do is get a liter bag of normal saline and 5% dextrose. And then you take 100 mils of that out and add 100 mils of 50% dextrose. So it's basically, all you need to chart is 900 mils of normal saline and 5% dextrose plus 100 mils of 50% dextrose, and the nurses will fix that up for you, and you can always check the recipe. So you can give that fluid at maintenance rate if they're not dehydrated, and that will clear their ketosis to the point where you should not do any more sugar or ketone monitoring. You can follow them clinically. It will clear their ketosis effectively, and they'll feel better. All right. If, however, we have a dehydrated kid who has gastro, for example, and specifically gastro, I guess, and you're going to rehydrate them and they're also quite ketotic, I would suggest you do just use normal saline and 5% dextrose using the rapid rehydration protocol. Now, the reality is that the rapid rehydration protocol, actually, if you check a sugar midway through that, a lot of the kids are actually quite hypoglycemic. So, which is fine because they have working pancreases, so they just sort that out. But if you actually if you're going to give rapid rehydration, then it is worth checking the sodium, because your sodium has to be between 130 and 150 to be able to safely give a rapid rehydration protocol. The diagnosis has to be clearly gastroenteritis, because that's the only studies that we can demonstrate safety for it for. And just be a little bit wary, I would say, clinically, of the potassium before you start, because if you are giving rapid rehydration, it's quite actually a lot of sugar in that 4 hours that you're giving it. So even though the concentration of the fluid isn't that much, it's a large amount of sugar. So the kids actually will sometimes have sugars of 23 or 25 if someone tragically checks it. The only thing to remember is that will drive up their insulin production, and then occasionally I've seen their potassiums come down because of the hyperinsulinism. So that's not, fortunately, that just doesn't seem to be a problem with most of the kids, but it's worth thinking about if you're prescribing rapid rehydration protocols. So last point is, if you have started a child on rehydration with the right substrate solution, there should be no need to repeat the check unless checking their ketones, unless there is a very specific patient-specific concern. So getting finger pricks is distressing for kids, and particularly if you have them on a 10% dextrose solution, they will clear their ketosis without difficulty, and you can go clinically. So overall, there's a lot of debate about the use of ketones in the initial assessment of a child. I like it because I feel like it gives me the data of their substrate, and then I can think about the clinical signs of their hydration. Some people go, you could just go clinically, and that's totally fair enough. But I do think the repeated checking of ketones in the department is not helpful unless there is a very specific patient reason, and I can't really think of any hypotheticals at the moment. The DKA is obviously a very different story. So that is my overview and thoughts on ketones. I hope that is helpful. Cheers.